Grand Rounds. This morning, I'd like to introduce to you our speaker, Dr. Elizabeth Sinclair. Dr. Sinclair is an assistant professor of pediatrics in the Division of Gastroenterology here at UPMC CHP, where she is the medical director of the Feeding and Swallowing Clinic, the co-director of the Center for Eosinophilic Gastrointestinal Disorders, the EGID Clinic, which manages, among other things, eosinophilic esophagitis, which is the topic of her talk today. She's a native of Chicago and attended Brandeis University and got her doctorate in medicine from Tufts University. She then left Massachusetts and traveled to Oregon, where she completed her pediatric residency, came back across the country to Atlanta, Georgia, where she completed her clinical fellowship in GI. She came here to Pittsburgh straight out of fellowship, and in a word, has been a powerhouse with regard to clinical program development here in Pittsburgh. When I think of the upper gastrointestinal tract, I think of Elizabeth, no offense. Anything esophagus or upper intestinal, she seems to have a hand in. Since her arrival, we've watched the growth of the Feeding and Swallowing Center. She was the driving force in the button battery protocol that we have in the emergency room to help with kids who swallow button batteries. She even found time as being the physician lead to help co-lead the G-Tube clinic, which is now co-managed with pediatric surgery. Her first, love, remains eosinophilic esophagitis. And with her co-director, Kristen Critelli, we've watched the EOE program in the EGID Center grow from, I think it was about 100 patients per year in 2021, when she started to about 700 patients last year. So it's really had tremendous growth over time under her leadership. And I would not be remiss to mention her passion for advocacy and advocacy for patients. She was just mentioning how she got the State House to light up purple for Eosinophilic Esophagitis Awareness Week for the past 2 years in a row. And I think it's part of this passion that she wants to bring the concepts of eosinophilic esophagitis to the masses here today and to teach a little bit about this disease process. Here at Children's Hospital, about 70% of the women, the faculty here are women. We just finished celebrating Women in Medicine Month. And for any female faculty that are out there looking for a role model, I would present to you Elizabeth. She's a wife, a devoted mother, a superior clinician, and a leader in the Division of Gastroenterology. Her ability to be productive in these many facets of her life is not only really respectable, but it's truly amazing. And so to you, I present to you Elizabeth Sinclair, who's going to give us a talk this morning on EOE.
Thank you so much for that warm welcome. So this talk is, he's right, it's my first love. I came to Pittsburgh to help grow this center with Dr. Critelli, who founded it. We'll talk about that at the end. But this talk is called Eosinophilic Esophagitis, a comprehensive update on an increasingly common allergic condition. I don't have any financial disclosures, but this talk is part of the NASPGHAN Foundation EOE Grand Rounds program that I was elected to. And so all of the blue slides are part of the program, and the purple slides are the slides that I've edited or kind of adjusted based on the content they asked us to present. So the agenda, we're going to do an EOE overview, talk about epidemiology, clinical presentation, diagnosis and pathophysiology, treatment, and then we're going to switch gears and talk about the EGID Center that we've grown over the past few years and talk about the future. So the learning objectives are to understand that the clinical presentation of EOE varies with age. We're going to define the criteria necessary to make the diagnosis of this disease, define the long-term consequences, like why we're treating it, why this is an important disease, and understand the rationale for the different treatment options. So first, we're going to start with the natural history of this disease. So what is EOE? We mention it to patients. We say eosinophilic esophagitis, and they're like, what is that? That's a mouthful. So we call it EOE for short. It's a chronic immune-mediated disease that's characterized by symptoms of esophageal dysfunction and eosinophilic infiltration of the esophagus. You have to have more than 15 EOs per high power field to make this diagnosis on biopsy. There's no other way to diagnose it at this time. It's the leading cause of dysphagia and food impaction in children and young adults, and it's the most prevalent cause of chronic esophagitis after GERD. And we know that it progresses if you're not going to treat it. People used to think that you could grow out of it like childhood eczema or childhood asthma, but the truth is that you're not going to grow out of it. And if you don't treat it, it's only going to get worse. It's chronically progressive, and it starts with inflammation, leads to fibrosis and scar tissue, and that fibrosis heaps up and leads to narrowing of the esophagus. It requires long-term treatment for life. If you stop treatment, your symptoms are bound to come back within about a year. So who gets EOE? We'll talk about that a little bit more. The answer is more and more people. Both the incidence and prevalence rates outpace an increased recognition of this disease. We'll talk about that in diagnosis a little bit later, but because this disease wasn't well recognized, some people thought that this was sort of artificially inflated by increased diagnosis, but it's not. This disease is rising, similar to other immune dysregulation disorders like Crohn's disease, type 1 diabetes. It really suggests that there's environmental factors contributing to the rise. And then we talk about genetics and heritability. Things we know absolutely is that it has a male predominance. There's sort of a 70 to 75% male predominance. We don't really know why, because certainly it occurs in kids before puberty. So we don't think it's necessarily hormonal. And there is a stronger disease concordance in dizygotic twins compared to non-twin siblings. However, I will say this data is a little bit outdated. It's from about 10 years ago, as the diagnosis was kind of in flux, and we're hoping that there's going to be more updated data soon, because boy, do we see families in our clinic where they're describing their symptoms, mom and dad are there, and I say, oh, you know, are you having trouble with food? Here are your symptoms. And then mom slowly looks over to dad and says, that sounds a lot like you. We've got to get you to the doctor too. So EOE and associated environmental allergies. So 2/3 of EOE patients have other allergic conditions. Allergic rhinitis is the most prevalent, followed by asthma, IgE, food allergy, and then eczema. So these are atopic kids, because families ask, well, why do I have this? You have this because it runs in your family, and this is just the type of immune system you have. We don't know exactly what triggers it, but you are prone to it. What's the clinical presentation? So as I talked about, the clinical presentation varies by age. Younger children tend to have more feeding difficulties, vomiting, gagging, chronic cough, picky eating. As they become older, it's more heartburn, belly pain, throat clearing. And as they become adolescents and young adults, there's a lot more regurgitation and dysphagia. This graph shows that as kids and adults get older, you see that there's a lot more dysphagia, and things like vomiting and growth failure go down because kids adapt over time. They figure out what foods they can't eat and find ways to grow with a diet that they're self-modifying. So you really have to take a careful history, because the signs and symptoms can be really nonspecific. No one, with few exception, comes into the office really complaining of difficulty eating or dysphagia. You really have to kind of pull it out of them. And young children, you want to ask about their feeding behavior, vomiting, food refusal, and be attentive to their growth. School-age children may express pain as a more primary complaint, and from just a history, the symptoms can be indistinguishable from reflux. Adolescents are more likely to express actual dysphagia and difficulty swallowing, however, and food getting stuck in their throat. We have a mnemonic that we used called IMPACT. Ask them, because they're really not going to complain of pain with swallowing. It's more of a discomfort. Do they drink a lot of fluids with their meals? Are they always using ketchup or ranch? I had a kid last week who puts their mac and cheese in ranch in order to swallow it, to make it more moist and easier to swallow. Do they modify their food? Are they cutting it into really small pieces, or pureeing, or only eating kind of soft mashed foods, especially if we're talking toddlers? They didn't make it to that table food stage. Are these meal times really prolonged, or the opposite, so short you can't get them to sit at all because they don't want to put anything in their mouth? And is that being attributed to behavior? But the behaviors have developed because they're really having a hard time eating. They avoid hard texture foods like meats, chicken, steak, rice, and uncooked vegetables. Do they chew excessively, or in teenagers, moms will say the opposite? Oh, he just doesn't chew his food. He's just swallowing it down. But usually that's not the case. It's usually that they're having trouble swallowing. Or do they turn away pills or tablets when they really should be old enough to have that skill? Talking a little bit more about other patients that you might see with EOE, children with and without autism who have feeding disorders have an increased risk of EOE when compared to kids without feeding disorders. So for a long time, people really said autistic kids who are picky eaters are that way because of all their sensory differences, because of their behavior issues, but really you can't separate it from EOE. They could have both. And so when I see kids in clinic who have picky eating that is beyond normal, like 2 to 5 year old picky eating hasn't improved or is really severe, I go looking for EOE because I don't want to miss it, especially because autistic children do have a lot of feeding difficulties. I want to see if I can make it better if there's an underlying medical issue that may not get better with behavioral therapy unless you address an underlying cause. So food impaction. This is an example of a 19-year-old with EOE who came in unable to drink liquids and actively spitting secretions into their spit bag in the ER. When we went and checked under endoscopy, there was chicken right stuck in the throat. And you can see, we'll talk about in a minute, the features of EOE, including a pale esophagus, furrows, and these are actually white plaques, not leftover chicken. And speaking of food impaction, this is just a preview, but we're going to have a new ER clinical pathway on who to call if there's a suspected food impaction. And the answer to that is GI. Always call GI. Don't call ENT. And it's only because we have different and honestly better tools to remove a food impaction. We have this new tool that's about 5 years old called the excavator. It opens up like a bird beak and can suck the food up and pull it out. It attaches to our flexible scope. This device is not available with a rigid scope, and otherwise, without this device, you're literally picking at meat or a food impaction with biopsy or other kinds of forceps, kind of fiber by fiber, and it can take hours to remove it. So call GI if there's a food impaction. We are here to help. So what are the complications? You already saw some of them. Food impaction, esophageal stricture. So again, like I talked about, this disease is going to get you if you don't take care of it. 60% of people will develop strictures after 10 years of untreated disease, and it rises to 70 to 80% after 20 years. And the biggest problem is food impaction. You're in the ER with food stuck in your throat. You can have esophageal perforation as a complication of dilation or a food impaction. There can be growth issues. There's a lot of mental health issues because people will avoid food, not be able to participate in social activities like parties, sleepovers, dates, because they're worried about what they're going to be able to eat or being judged about the way that they eat. Feeding difficulties are very common. The good news is there are no reports of increased cancer risk for this disease at all, as far as we know. So psychological dysfunction, we do have these surveys that help assess how much the quality of life is being affected by your EOE. And there was a review that found 69% of EOE patients have some kind of psychological dysfunction associated with their EOE. There's social difficulties, again, mealtime stress, need for a feeding tube for some kids, anxiety, depression, and a lot of school problems. And I'm going to talk about the ENT perspective as well, because I work in our aerodigestive center, and there's good data that 10 to 15% of patients eventually diagnosed with EOE actually see ENT before they see GI, because the age of presentation to ENT is younger. Kids are showing up with recurrent croup, loud breathing, recurrent ear infections, and they may get diagnosed with EOE before they even see GI and have developed their GI problems. So the other thing to know is there's an increased failure rate for reconstructive surgical procedures in ENT. So I work with our colleagues when patients have EOE and they're undergoing some kind of ENT procedure to make sure their EOE is under control before they undergo this surgery. And we have partnered with our ENT colleagues, and they actually will take biopsies for us in patients they suspect EOE if they're in the OR, which is really helpful because I think we are getting this, this age down from 10 years old. So radiological findings, what might you see if you do an esophagram for a patient with EOE? And that's really the best test to look for any complications of disease. You can see rings, we call it trachealization because it really does start looking like a trachea. You can have an esophageal stricture, or you can have a small caliber esophagus. I tell kids that they shouldn't do it, but teenagers should be able to swallow a quarter and it won't get stuck. However, we have seen patients who have an esophagus the size of an infant's. Their entire esophagus has become narrowed because of their chronic disease. And I tell patients that I can't predict if they're going to have a single point stricture along the 30 or 40 centimeters of their esophagus, or if it's going to affect the whole thing. And so that's why we need to treat it. So what are the endoscopic findings? Again, we talked about how this disease is only diagnosed by esophageal biopsy. We don't have a lab. Radiology can't tell us that's what's going on. It can give us a hint that there's a problem, but you can only diagnose it by endoscopy and biopsy at this time. Here's a normal esophagus. You can see that it has a lovely pink color. You can see the blood vessels clearly. Next to it is an EOE esophagus. You can see how pale it is, and you can see the long lines running down the length of the esophagus. And this example doesn't have plaques, but I will show you in the next slide plaques that look like a snowstorm or could be suspicious for Candida, but it's actually EOE. And for those of you in the room, I actually have a model on the side table you can check out looking at the progression of EOE. So we have a scoring system that looks at edema, rings, exudates, and furrows. It's a validated score that if you receive a certain number of points, you're very likely to have EOE, but you still have to take biopsies to confirm it. So considerations, again, for my ENT colleagues, because my GI colleagues and I are all on the same page having standardized our biopsy techniques. You need 6 biopsies because this disease can be patchy and can affect the lower, mid, or upper esophagus, or all 3, or a combination. And the other thing is, if EOE is suspected, biopsy should be taken even if it looks normal, because they may not have developed those endoscopic findings yet, but they still could have active disease that needs to be treated. And then if an endoscopy is performed for a food impaction or a foreign body like a coin, then esophageal biopsy should be obtained too, because there's some data that shows food impactions absolutely are a red flag for EOE, but even coin ingestions, there is a 5 to 10% pickup rate. So if they're under anesthesia, you might as well get biopsies while you're there. Well, so we'll talk about histology, again, that gold standard, how we diagnose this. This is a normal esophagus. You can see the epithelium, the lamina propria, the submucosa, and the muscle layer. In a normal one, remember the rough size of the basal layer. In EOE, this basal cell layer expands. It's almost double or triple the size. And you see an infiltration of eosinophils, dilated intracellular spaces. You can see all that white space in the basal zone. And then in lamina propria fibrosis, you can see all that pink scar tissue that shouldn't be there. So pathophysiology, again, how do you get EOE? Well, we don't know. We know that you can have a genetic predisposition if you're atopic and you have some kind of trigger. Is that trigger food? Is it an environmental allergen? Is it a virus? We don't really know. But once you get triggered, your EOE is on and it's not being turned off. And it is a Th2 mediated disease that sets forth all of this inflammation that brings eosinophils down into the esophagus, leading to inflammation and eventual scar tissue. And we'll talk about some of the targets because IL-4 and IL-13 are involved in this disease, as well as eotaxin 3, and some of the medications we use target those points in the pathway. So we're going to move on to treatment. There are 4 medical treatments. We'll talk about dilation after 2, but 4 medical treatment options for EOE. There's proton pump inhibitors, topical steroids, diet elimination, and biologics. So we'll start with PPIs. I know that There's been a lot of press about PPIs, and we, even as GI doctors, are trying to minimize the use of PPIs when they're not necessary. But in this disease, when they work, they are a necessary and effective and fairly low risk treatment options in the scheme of things. And so this has actually been a really confusing treatment option, because for a long time, people thought that PPIs just reduce the acid, and then PPI EOE was this own entity, this type of reflux that was a little different from reflux, but wasn't EOE. However, over time, it has become really clear that because the PPIs work to block the eotaxin that is totally separate from their acid blocking abilities, it treats EOE. So Pepcid or famotidine is not going to treat EOE, but PPIs like omeprazole and Nexium are. And you need higher doses than you would give for acid blocking. You need 1 milligram per kilogram twice a day for a max of 80 milligrams a day. So our teenagers are on 40 milligrams twice daily. There also is an unclear relationship between GERD and EOE. Does GERD act as sort of that first hit that injures the esophagus and then allows the trigger to set off EOE? We don't really know, but maybe. So we treat GERD when we find it as well if it's co-occurring with EOE. So this is one of my favorite slides that clearly explains the difference between PPI responsive EOE and GERD. So this shows that the transcriptome signature in EOE and PPI treated EOE is the same. This solidified the diagnosis that PPI-RE is just EOE that is responsive to PPI. It is no different than regular EOE, and it is distinct and different from GERD. So that's what helped cement it as one of our mainstay treatments for EOE. Caution, PPIs have side effects, right? It's all over the news all the time. The absolute risk of PPI therapy in kids is controversial. There are all these potential side effects. However, it's also relatively safe with few short-term side effects. There's a lot more research that's needed into the long-term PPI therapy for EOE to characterize the safety concerns. But what I tell families is we do know that if you don't treat it, you're going to get worse. And so we have to find a treatment option. And I tell families that you might not be on this treatment forever. You're going to be on a treatment. And so maybe if this treatment works for you for 5 or 10 years, by then we'll have a different treatment that's a better fit for you. And this is just a slide one of my colleagues made that just summarizes the PPI adverse effects sort of based on the strength of the evidence of the various studies. There is some good evidence for concern for acute interstitial nephritis, B12 deficiency, iron deficiency, and hypomagnesia, and maybe fractures. And so for all of our patients who are on chronic PPI, we do labs once a year looking at their electrolytes and assessing their kidney function. The nice part about PPIs too is that there's so many ways to give it. You can have a pill, you can open the capsule, there's a liquid, there's a dissolvable over the counter, there is a packet, and it's cheap for the most part, except for that compounded liquid. So we can almost always find a way to give it to patients. And some people can be decreased to daily dosing. We start with twice daily dosing because the effectiveness is in this 30 to 50% range. So when it works great. If it doesn't work, we're not surprised and we don't get bent out of shape about it. So the next treatment is topical corticosteroids. This is a really interesting treatment. I really value the creativity of the GI colleagues who realized that we could treat EOE this way. So the way this works is that you get budesonide respules, those pulmonary respules that our asthma colleagues use, and you pour it into a medicine cup, and then you mix it with Splenda, honey, or chocolate syrup so that it's thick. And then you swallow it down so that it coats your throat. And I tell families that it's like trying to put eczema cream on eczema, except we're trying to get it inside, limited to the esophagus. And then the other way it can be administered is through a fluticasone HFA. They puff into their mouth and they swallow it. I will say that not every child can do it. Young children have trouble, especially if they're used to inhaling their puff. They can get confused about learning to also swallow a puff. There's likely minimal difference in the efficacy between these two options, but if one is not working, sometimes we switch to the other modality. We're using fluticasone a lot less because of that insurance issue that happened a couple of years ago that made it very difficult to get. And then more recently, there's an FDA-approved pre-mixed version of budesonide called Eohilia. It's cherry flavored, and it comes in this little kind of slurpy packet that kids can drink. I will say that the dose is higher than we use for a lot of our patients, and so we're not using it super regularly because if I can get away with a lower dose. The other thing is the cherry flavor. Not everybody likes the cherry flavor, so although our kitchen chemists make it is difficult in some ways for our patients because they have to home mix their medicine twice a day, they do get a little bit of choice in what they're drinking. And this is a study that our group, our national working group, did together where we took a survey of what people use for their mixer. Splenda is the most common because it was studied the most scientifically. Honey, maple syrup, chocolate syrup, an agave survey syrup also kind of were the most common, but I have a number of these are my patients. I have a patient who does it with Jell-O powder. I have a patient who does it with peanut butter, and I have a patient who does it with yogurt. So we also tell patients that if their budesonide isn't working, but they say they're mixing it appropriately and not missing doses, sometimes we change the mixer, and we've had efficacy improve. So what are the adverse effects of topical corticosteroids? The biggest one is thrush and esophageal candidiasis. This says up to 15 to 20%. I think that's more in adults. We don't see it that high, probably 5 to 10%. I've only had 1 or 2 patients actually have to come off of it because of recurrent candidiasis. There's conflicting data on if there's growth or adrenal suppression issues. Our endocrine colleagues maybe get a headache when we do labs. Because we check ACTH and cortisol yearly to make sure patients aren't having any adrenal suppression. It's much more likely the higher the dose of the topical corticosteroid, and it's also much more common if they're also on an inhaled steroid for their asthma. So we check it. In the adult world, they don't check it because it's not a major concern. And I, again, have maybe had 1 or 2 patients have real adrenal suppression that we think is due to their topical corticosteroid. So the next option, the non-medicine option, dietary therapy. So back in the day, people would go really extreme and put patients on an elemental diet. They would be drinking Elecare or have a G-tube, no other foods in order to treat their EOE. And then they would do a 6-food elimination diet, which is dairy, wheat, soy, eggs, tree nuts, and seafood. And then they would sort of start doing this step-down therapy. This is, again, a little easier in adults. Adults can make those choices, and we don't have to worry about growth in adults. But in pediatrics, this is really hard and can lead to more feeding difficulties, more picky eating, food aversion. And so over the years, there have been more studies that show you don't have to start from the top. You can actually start from the bottom. So you can start with a 1-food elimination diet and have a 50% success rate, which there's really not that big of a difference between a 6-food and a 1-food elimination diet. So our standard right now, for the most part, is to start with a 1-food elimination diet. And then this is targeted elimination diet. That's based on allergy testing. You have a less than 50% chance of that working. And because this disease is TH2 disease instead of IgE disease, we actually don't recommend allergy testing at all for these patients because it can lead to unnecessary food elimination. And so who are the culprits? And milk, it's always milk, and dairy is the allergenic identified food most commonly. So that's what we start with. After that, it's wheat, egg, and soy. And I honestly, because the pickup rate is so low after those 4 foods, if families aren't successful after a 4-food elimination diet, I really start to consider recommending medications for them. Again, because I have told patients and seen it myself that it's not always the food. It could be your dog. It could be the oak tree in your yard that's your trigger. And because we can't test for it, nor could we eliminate it if it was environmental, that some people will need medicines no matter what. We have G-tube fed patients on elemental diets who still have EOE. So it's not always all about the food. I will say I have some patients who will report a trigger themselves, that they think it's a specific food that makes their throat kind of itch or make their dysphagia worse. And if they're pretty confident about it, we may eliminate that food and do kind of a one-time trial if they really don't want medication and to have a suspicion. So again, I talked about allergy testing in EOE. It's not recommended. Most EOE patients have 1 to 3 food triggers that contribute to their EOE, but again, some of them don't have a food trigger. It's an environmental trigger. And it just doesn't provide useful information. And overall, because I'm also a feeding doctor, I really don't want kids eliminating food from their diet that they don't need to for a medical reason. So take-home points. Dietary therapy needs to be discussed with all our patients and families. We offer it if that's something they want to do. It's usually empiric, and we do step-up therapy these days. Patient selection and support are critical. It has to be family-centered. We work with our dietitians very closely. And again, it has to work for the family because eliminating these diets is very expensive and not covered by insurance at this time. And schools are not always on board. I have had patients where I wrote a letter saying they have an allergy to dairy because of their EOE, and their child still got a chocolate milk put on their tray every single day. And she was 8. And so she was going to drink her chocolate milk. And so we ended up abandoning dietary therapy because we could not get the school to comply with eliminating dairy from her school tray. So next we'll go to biologic therapy. So dupilumab or Dupixent. This has been a game changer, honestly, for our EOE patients. It's an IL-4 and IL-13 blocker. It's approved in patients 1 to 18. It's weight-based dosing. The smallest child you can give it to for EOE is 15 kilos. I will say our kids are usually not 15 kilos, so they're close to 3 or 4 years old. The efficacy in adults is about 65%, and we're seeing it anecdotally closer to 80%. I think we've only seen 1 or 2 patients that it hasn't helped at all on. It's really a powerful drug for these patients. I will say that there's no data in pregnancy, so when we're talking to our older young adult females, we have to talk to them about that. And then there is a warning on the label that says this is not safe for live vaccines to be given. However, it's really just because it hasn't been tested, and Quad AI does recommend giving live vaccines. But I have had some patients, wait to get they'll get their MMR and varicella and start Dupixent afterwards, or maybe we'll skip a dose or 2 in between, but there's not a huge safety issue. And given the new concerns for outbreaks of measles and other vaccine preventable diseases, we recommend kids get vaccinated. So how do we approach discussing therapy with our patients? We lay out all the treatment options and what each entails. We talk about a PPI trial, solid steroids, an elimination trial, or biologic therapy. Shared decision-making is key. The patient and the family have to agree to this therapy. I have had a number of patients where mom wants the shot, the kid does not want the shot. And so he's not going to get the shot if he doesn't want it. Or they're not going to comply with that dietary elimination. Mom can control what he gets in the house, but if he's out with the guys from his soccer team and everybody gets pizza, he's probably going to eat pizza. And so you really have to have a thoughtful discussion, and it's shared decision-making. So this is just a table summarizing all of the treatments that we talked about today. And then I'll talk about dilation a little bit. So strictures in pediatric EOE, they're rare, but we do see them. The prevalence is about 8% in kids versus 25% in adults. It's chronic esophageal inflammation increases the risk of fibrosis and stricture formation, and it requires mechanical dilation to prevent future food impaction. It's indicated when kids have esophageal narrowing on their esophagram or persistent dysphagia. And so the dilation techniques that we have are a balloon dilator. You literally blow up a balloon in the esophagus and stretch and tear the esophageal tissue in order to widen it. There's also the wire-guided polyvinyl dilators. They are solid core dilators. Those work for longer strictures or narrowed esophagus, if it's the entire length of the esophagus. And then there's a new tool called EsoFlip and EndoFlip. It's a balloon dilator with a bunch of probes on it that can help measure the distensibility of the esophagus and help pick up more subtle strictures and really give you good feedback on how well the dilation occurs, because you can measure that improvement in distensibility. So disease monitoring. Our current best objective to measure EOE is the number of EOs per high power field. It's unclear if there should be 0 or just less than 15. Most of us target less than 15. Symptoms correlate poorly with histology. So kids will say they feel so much better. So why do they need another scope? Well, they're not very reliable. And I also tell patients that partially treated EOE is kind of like high cholesterol. You feel totally fine until you're in the hospital with a heart attack. You might feel totally fine until you're in the hospital with a food impaction. And I don't want that to happen to them. And I also tell them that they need to use their esophagus for the next 70 years. And if they get a really bad stricture, we can't cut it out and put their esophagus back together like you can with other parts of the bowel. So we really have to do our best to keep it healthy. We repeat an EGD when symptoms return, or we introduce a new food or change treatment. We also are repeating EGDs every 1 to 3 years, even if they're asymptomatic, especially while they're growing, because kids can outgrow their dose of PPI or budesonide, or some of these medicines wear off, or a new environmental trigger re-triggers their disease. Take-home points: the incidence of prevalence of EOE is rising. EOE is a chronic progressive immune dysregulation disease. It's more common in patients with atopic history. It's more common in boys, kids with feeding disorders, and autistic children. The diagnosis has to occur off PPI because PPI is a treatment, and off steroids if you can. I had a question at an ENT conference that said, how long should you wait to do a scope if a patient has gotten steroids for their croup? And I say, if you can wait at least 8 weeks, it's sort of unclear since, the treatment for croup is a lot shorter acting compared to if a kid gets like a pred pack or a longer pred taper, but nobody really knows. And so to get the best information, you wait longer. Allergy testing is not recommended. And again, it can only be diagnosed and reassessed by biopsy right now. And they require lifelong monitoring and endoscopies. So now I'm going to switch gears a little bit and talk about the center that we've developed here at Children's. So Dr. Critelli established it in 2021, and then I came by later that summer, and we have built it up to include our nurse coordinator, Catherine, who we cannot do this without. I can't stress that anymore. She does teaching for our patients who start Dupixent. She does our transnasal endoscopy. She convinces our patients to be adherent to our therapies, and she helps us fight the good fight with insurance. We recruited Helena Wolacek to our clinic. She is a nurse practitioner, well-versed in EOE. And then we partnered with our allergy colleagues. Dr. Jordan runs a parallel clinic that patients can see an allergist on the same day as they come to be seen for their EOE. And then we also work with our dietitians. We worked with our pathology department to standardize the information we're getting on our results. We've worked with the procedure center to bring transnasal endoscopy, and our prior auth specialists also, we cannot do this without. So I talk about the EGID Center and academic medicine. The pillars are clinical care, education, research, and service. Many of our meds are not FDA approved for EOE. And so we're doing a lot of research and education in order to get these patients what they need. Our services are to evaluate all of these children, diagnose them, and support them through their EOE disease and recovery. And we have had so much growth. We have greatly improved the number of patients receiving a follow-up EGD after diagnosis of their EOE, and our annual EGID Center visits have skyrocketed over the last 4 years. And we are committed to innovation. I mentioned it a couple of times, but we started doing unsedated transnasal endoscopy just last December, and we've done about 50 cases. This is where the patients are fully awake. We apply topical anesthetic to their nose and the back of their throat, and then we stick our bronchoscope down their nose into the back of their throat, and we take biopsies. And these are a couple of pictures of a recent patient. Now, you can't see quite as well because we're not insufflating, but for patients with really well-controlled disease, we are able to provide this unsedated service for them. And I want to thank Dr. Toby for training us on how to navigate the nose. So education. We've developed 5 different EMR documents detailing EOE and the treatments. We had to get them updated again because besides dupilumab and newly approved Eohilia, the medicines are not FDA approved. So pharmacy doesn't have sheets on how to dose and provide these medications. We do medical student, resident, and fellow education. And Dr. Critelli is very active in the School of Medicine. We also are invited to 1 to 3 lectures locally and nationally to help educate both within the GI community, the general pediatric community, the ENT community, and the feeding and aerodigestive community. We're also doing a little bit of research. So one of our recently graduated fellows compared adherence in EOA on patients on non-injection medication and dietary therapy and found that patients had actually a lot more trouble with their twice daily medications than doing a dietary therapy, which was very interesting to us. Although the biggest problem the dietary therapy patients had was they suffered from more food insecurity because it's very expensive. We're collaborating with Nemours in Orlando to look at the pharmacogenomics of PPI treatment in EOE, because as I mentioned, that medicine only works about 50% of the time, and we're really not sure why it doesn't work more. We are currently, with a current fellow, investigating the presentation and treatment of patients with a dual diagnosis of celiac disease and EOE to see if they can respond just to a gluten-free diet, to see if their disease is similar to EOE without celiac disease, to see if it behaves differently or similarly. And we're also looking at patients who have inflammatory bowel disease and start a biologic or another immune modulating therapy and then develop EOE afterwards, but didn't have it prior. So our vision for this center is to expand our team and grow it. We've done that well. One of our next steps is to incorporate behavioral health into it because, as I talked about, a lot of these kids have anxiety around meal times that doesn't go away, and they've developed these maladaptive feeding behaviors that have persisted for years. I've had kids say, I want to do feeding therapy because I want to go to Disney and know that I can try new foods and not be worried about it. We updated our website. We are increasing access and providing educational resources, and we're providing the most up-to-date care as new FDA medications are becoming available. We are making sure that patients are adherent to their therapies before they have a scope. Boy, will I cancel a scope if the patient comes in and says they haven't been taking their medicine, because I don't want to put them under sedation just to see their active disease. We ensure standardized biopsies and scoring in our patients during endoscopy. We started this transnasal endoscopy. We want to consider some newer equipment that can give us better visualization. We partnered with pathology to help provide standardized reports, and including our centers in Hammett. The next step is to investigate EndoFlip to better understand esophageal distensibility and help provide relief to patients who are still complaining of dysphagia, but their disease is in clinical and histological remission because some of their fibrosis can persist. We have a growing reputation. We are members of our national working group's special interest group. We joined the AppFed provider directory. We appeared on That's Pediatrics back in 2021. There's leadership at the School of Medicine with Dr. Critelli, and we have a national presence in both feeding and ENT subspecialties. And we are working on a quality initiative with some of the data I showed you showing we are having improved follow-up, and we're working on to see if that is translating to improved remission rates. And then we like to participate in research, collaborating in clinical, translational, and our drug trials. One day we want to join Seeger, although that we're having trouble with that at the moment. And then we're working on transition of care. When we first got here, there were not really adult providers who were familiar with EOE. And we communicated with both of the groups, because when patients come here, we take all insurance, but when they become 18, they may not have a choice where to go. But we want to make sure their EOE is being taken care of. And so we have colleagues at both of our partners who are more comfortable and standardizing the care of these patients, especially as Dupixent has become available. We want them to be partners with our patients because our patients are graduating empowered and knowledgeable about their disease, and they want to continue to get the great care that they've been getting as children. And then also coming up, hopefully, is that I keep selling to my patients is there's this orodispersible budesonide pill. You swallow it and it foams like an Alka-Seltzer tablet to coat the throat. It's available in Canada and Europe. It's in clinical trials here, but I keep telling some of my patients who are on budesonide that they can just hold out a little longer because I think this pill is coming, but I don't know when. And then again, just a brief plug for EndoFlip that can provide more information for our parents and patients. So, and these are our partners. There are so many groups who are actually dedicated to taking care of patients with this rare disease. And then, as Dr. Rudolph mentioned, I am an advocate. I am an active participant for National Eosinophilic Awareness Week, and there is a National EOE Day, May 22nd. It happens every year. We had the first one in 2025. I was at the Capitol the day before the shutdown, advocating for the Medical Foods and Formulas Act. This act advocates for formulas to be covered for patients who take it orally or by G-tube, and that it should be covered like a medicine because it is a medicine, and patients shouldn't have to pay out of pocket for a medically indicated formula. And then AppFed partnered with Viewpoint with Dennis Quaid back in January, and they did a TV spot. And then if you are traveling this holiday season, a number of airports and bus stops, bus stations around the country have billboards up for EOE national awareness. And then I was talking about CGER a little bit. It's the Consortium of Eosinophilic Gastrointestinal Diseases Researchers. And unfortunately, their funding was cut this summer. We are hoping to get it restored, but we are kind of on pause on trying to join them because their funding is shut down at this time. And then it's always about the patients. This is Anna. She is one of our patients who just graduated high school, but she initially presented to the ER with an ibuprofen pill stuck in her throat. She didn't know she had EOE. She just said, "This is stuck in my throat and I'm really uncomfortable." We did an esophagram and she refluxed the contrast right up out of her mouth because this pill was so stuck in her throat. We did an endoscopy, found the pill still present, removed it, and she really had a stricture, so we dilated her. Unfortunately, she had a very rare complication and had a perforation, a contained leak of her esophagus, and she needed to spend the entire summer on NG feeds while we let this heal to avoid surgery. And it did. She healed great, and she was a trooper about it. She asked me that summer if she could ride a roller coaster with her NG, and I told her no, but she could probably do the merry-go-round. And then she was featured in the Tribune this summer after graduating high school because of her medical journey. She's been inspired to go into medicine. And so that is all I have today, except for also a plug for Halloween. As a GI doctor, I dress my children in food-related costumes until they tell me they don't want it. And so you can decide who wore it better in terms of my pineapples and hot dogs. Thank you.